So welcome, everyone. Thank you for joining us today. My name is DC. I'm a genetic counselor and medical writer here at Ambry. We're pleased to be offering you this unique one-hour webinar. And we're honored to say it's also been professionally endorsed by the Canadian Association of Genetic Counsellors. Our two experienced genetic counselor speakers from Canada and the U.S., Jenna Scott and Christine Kowalka, will focus on cross-border issues in their informative and insightful presentation. Jenna and Christine will review their objectives when they begin, so I won't spend some time on them here, but let's just say you are definitely in for a treat. So with that, I'm thrilled to introduce our speakers. I'm so grateful that they agreed to take time out of their busy schedule to put this webinar together. I know they've gone through a lot of trouble. Certainly, we appreciate that. So Jenna Scott is co-director of the University of British Columbia's Master's Program in Genetic Counseling, with a focus on curriculum design and directed studies research. Since she graduated from Sarah Lawrence College in 1994, Jenna's worked in prenatal, pediatrics, and adult genetics, with 15 years of experience in clinical cancer genetics itself, including as clinical coordinator of the BC Provincial Hereditary Cancer Program. Most recently, Jenna has investigated genetic counselors' experiences with integrating multiplex cancer testing to inform changes in service delivery, highly relevant to today's topic. Christine Kowalka graduated from the University of British Columbia's Master's Program in Genetic Counseling in 2007, and she's been working in the Medical Genetics Department at Kaiser Permanente, San Francisco since 2008. She has a special interest and focus in cancer genetics, which she channels into a variety of roles. This includes integral liaison work with the multidisciplinary Women's Cancer Risk Clinic at Kaiser San Francisco, a clinic designed to meet the diverse needs of women with hereditary risk for breast and gynecologic cancers. Christine is certified by both the American Board of Genetic Counselors and the Canadian Association of Genetic Counselors, and she is also a licensed genetic counselor in the state of California. So with that, take it away, Christine and Jenna.
Great. Thank you, Deepti. So I'll advance our slides here and just first say that we have no disclosures to report. And these are our objectives. So first, we'll review key components of hereditary cancer panel use in the U.S. and Canada. We'll discuss commonalities, differences, and challenges to the above. And we'll offer some practical solutions to the U.S. and Canadian genetic counselors out there who are facing clinical dilemmas that cross-border issues may bring. So just to start, this is our outline. We will first talk a little bit about the healthcare between the U.S. and Canada. We'll talk about family history assessment, including approaches to genetic testing and cancer risk management. And we'll finally talk about some resources. So for some background, I wanted to show this slide just to show one of probably our most remote borders. So most of the Canada and U.S. shares the 49th parallel as a border. But this is the border up at Skagway, Alaska, which borders on British Columbia and is really close to the Yukon Territory. So this is the most remote place where our countries meet.
So Canada and the USA have very significant differences in our population density. You can see that the total population of Canada at approximately 35 million is almost 1/10 that of the United States and still about 3 million less than the total population of California, where Christine works. And while the majority of the Canadian population does live close to that 49th parallel, about 25% live in rural or remote communities. And one of the key challenges to Canada's healthcare system is providing accessible care to such a dispersed population. However, I think it's really important to recognize that both Canada and the USA face challenges with respect to healthcare access. And this is due to geographical issues in addition to other factors such as cultural or financial barriers. In terms of how healthcare works in Canada, Canada does not have a single national healthcare plan, but rather it has a national health insurance program, which is achieved by a series of provincial and territorial health insurance plans. It's predominantly publicly financed, but a privately delivered healthcare system. The system provides access to what's called universal comprehensive coverage for medically necessary hospital and physician services, and this is part of what is the Canada Health Act, and this is a law that Canadians tend to feel quite passionate about. It's important to highlight that it's not free. Payment comes from a government-run insurance program that every citizen pays into, and the amount that is paid is generally based on income. But since there's no need for marketing, no financial motive to deny claims, and no profit, this type of a universal insurance program tends to be cheaper and much simpler to administrate than the programs in the USA. One way, however, that costs are controlled is by limiting the medical services that are covered or by making patients wait to be treated. The system really relies on sort of a gatekeeper role. So that's most commonly the primary care physician, who would be the first point of access, and then would refer the patient on to other specialists as deemed necessary. I think also important to recognize that each province has a unique health plan, and as a result, what is considered universal may vary dramatically from province to province. So that includes, what might be part of newborn or prenatal screening options, what's provided for cancer care, and of course, access to genetic testing. So if there's a family that has relatives that are living across multiple provinces in Canada, what each individual can access with respect to genetic testing or cancer surveillance is going to vary from province to province.
Thanks, Jenna. And for the U.S., it's a much more mixed system. So in terms of how do people get care and how is it paid for, there's a few different categories. So one, under private insurance, an individual might have, someone may have medical insurance through their employer, which would be under a group policy. They may still have premiums attached to that, or copays, or deductible amount of money that has to be spent for the care, but it's given through the employer for the medical insurance. Another way that someone might have private insurance is through an individual plan. So if their employer does not provide access to medical insurance, they may have to take out a plan on their own. There's also several different branches of government-run medical insurance. First, considering Medicare, which is a federally run program, generally looking at people who are over 65 and disabled population. Medicaid, which is a state-run insurance, and typically thinking of low-income individuals falling into that category. And then the Veterans Affairs, so military insurance, people who have served in the military. There is still an uninsured population, and though that is supposedly decreasing because of the Affordable Care Act, which I'll talk some more about, those individuals would still have the option to self-pay for medical services. So how do people actually get their services? So in the hospital system, there are not-for-profit hospitals, there are government-run hospitals, and there are for-profit hospitals. So within that, it depends on the person's type of insurance as to how they would get their care. So for people who have HMO type of private insurance, Medicare or Medicaid, a primary care physician would need to refer a patient to other specialists. An individual who may have a PPO type of individual or private insurance would have the option to self-refer to their specialist. How much an individual pays and the cost associated with that can vary dramatically between any of these types of insurance, and it's individual based on their particular plan. So to move on to talk about family history assessment, we'll first talk about approaches to genetic testing. Starting with the path to genetic testing in the U.S., this is obviously a map of the U.S., and it's showing the population density, with red being the most dense areas and green being less dense. So as you can see, the population density is primarily along the eastern seaboard, points along the west coast, and major cities primarily in the Midwest to the east. The 5 most populous states in order of highest to lower are California, Texas, Florida, New York, and Illinois. Genetics clinics are spread all over the country. They're largely concentrated in cities. Large cities may have several genetics clinics. Smaller cities may just have one. More rural areas or towns, individuals may have to drive or even fly in the case of Hawaii or Alaska to get genetic services in person. Some clinics may have outreach, so on perhaps a weekly, biweekly, monthly, or quarterly basis, where a genetic counselor or other genetics professionals may go to more remote areas to provide services in person. Waitlists for genetics clinics can be long, depending on where it is in a large city. Some could be months, if not urgent visits. Where someone can go might depend on their insurance. So there may be affiliations between insurance companies and certain hospitals, so that may dictate where someone can get their genetic services. There may be options for telegenetics or video genetics, and so that might be an option for people living in more remote areas. And there are specific telegenetics companies that may work with insurance or allow patients to self-pay as an option. So continue on thinking of how do people get genetic testing in the U.S. So looking at this slide here, the first step is that a healthcare provider identifies either a personal or family history that might be significant. So that could be a primary care doctor, OBGYN, surgeon, oncologist. And for all of these steps along the way, coverage for genetic counseling or genetic testing depends on the type of insurance someone has. So just keeping that in mind as we talk through this. From here, it can go one of two ways. Either the healthcare provider themselves can order genetic testing, so any physician could order genetic testing themselves, or the patient could be referred by the healthcare provider to a genetics clinic or genetics professional for additional assessment and considering testing. So if we go down this path here, if the healthcare provider orders genetic testing, they have any number of labs across the country and any number of different tests that they could order at that point. So it's quite diverse in what could get ordered. If we just simplify it to say there's a mutation detected or there's no mutation detected, at this point, the healthcare provider themselves could just refer to cancer risk management, depending on the results and perhaps the family history, or they could refer to a genetics professional at that point. But that's not something that necessarily always happens. It doesn't have to happen. And so that's a link that may not always be there. If the patient goes first to genetics clinic and they have an assessment and then the genetics professional orders genetic testing, again, simplifying to mutation or no mutation and going to cancer risk management options at that point. One thing that's important to consider is that any step here, a healthcare provider or genetic counselor specifically may need to write a letter of medical necessity depending on the type of insurance, the family history, or what the insurance company is saying they will or will not cover. And that genetic counseling could be before testing or after testing or maybe not at all. I'm sure that there are people out there who've had the experience of a patient coming to a genetics clinic and being really confused about a variant or an uninformative negative, and so we know that there's a lot of different ways that people get genetic testing. Sometimes insurance only gives the patient one shot at genetic testing and would only authorize one test. So, for example, if an incorrect test is done at first, it may not be the correct test, and another test may not get funded, or it might be more difficult to get it funded. And because insurance companies have guidelines for what they will pay for testing, depending on the route that the patient takes to get testing, they really may not be the best person. Or if you look at their family history more extensively, it really may not be suggestive. And so they may still get the test. And this is kind of what can contribute to, one of the things that can contribute to the rising cost of healthcare. And of course, there's the option for self-pay testing as well. So this is just a slide to show that it can be really complicated. Different types of insurance, different types of coverage, even within the insurance, and where does the patient fit in the mix? Do they have more than one type of insurance? What is or is not covered? And where can they go for their care? So just to draw briefly on the Patient Protection and Affordable Care Act, also known as the Affordable Care Act, is the health care reform signed into law in 2010, and rules in the Healthcare Act actually govern insurance as part of it, and so they mandate that everyone has insurance. Part of what's in the Affordable Care Act also addresses family histories of breast and ovarian cancer, and the quote is mentioning that individuals who have a family history of breast, ovarian, tubal, or peritoneal cancer should be screened with one of several screening tools. So those are family history assessment tools to see if they may have an increased risk for a BRCA mutation. Women who, with positive screening results, so they do have a suggestive family history, should receive genetic counseling and, if indicated, BRCA testing. And if it's appropriate to do those, that it should be made available as a preventative service without cost sharing. So it goes on, though, to say that the final recommendation statement applies to women who have had no signs or symptoms of a BRCA-related cancer. So that's great for someone if they're unaffected and they have a known mutation in their family, but it's not so great if we want to test the affected best candidate, who would usually be someone who has breast, ovarian, fallopian tube, or peritoneal cancer. But the act is saying that it's as a preventative measure for people who have not had cancer, so it kind of misses the boat in thinking about, well, what about the person who's the best person to test first? It's also not addressing that these women who have had a first cancer are still at risk for a second cancer, so it can still be a preventative test for a second cancer for them. So these are some things we've already touched on a little bit, but talking about genetic testing with insurance, the coverage for genetic counseling and testing depends on the type of insurance. Insurance companies have their own criteria for genetic testing, and that may be similar to the NCCN. Insured patients may have different costs associated. Some people have a high deductible where they have to pay a certain amount of money before certain lower costs kick in. And some labs may have policies about out-of-pocket max to the patient when billing insurance, so how much the patient will actually have to pay, depending on what their insurance pays, and they may have financial assistance or payment plans. Most major insurance companies do not currently authorize multi-gene panels, but some labs are running panels at no extra cost when BRCA 1 and 2 testing is authorized. So I'm not going to go into this in any detail, but this is just to show you that across some of the different types of insurance that people might have, it's very complicated. You could have BRCA testing only authorized for an affected individual or only for an unaffected individual, and that this is only talking about BRCA testing. Some other insurance companies may have guidelines for other types of testing like Lynch syndrome, but in terms of the Affordable Care Act, there are no provisions for other genetic testing for cancer in the Affordable Care Act. So just to touch briefly here at Kaiser Permanente, Kaiser Permanente is California's largest nonprofit health plan. We are both the healthcare provider and the insurer. So Kaiser members receive care at Kaiser medical facilities. This is similar to how provincial healthcare operates, as Jenna will discuss some more. At Kaiser Permanente, Northern California, we service about 3.3 million members, which is most closely comparable to the population of Alberta. Cancer genetic counseling at Kaiser Northern California, our patients are referred to genetics from multiple sources, including their primary care, OBGYN, other specialties, or they can self-refer. A cancer genetics assessment here, we have cancer genetic testing is only performed through the genetics department. We have a regional task force that has a process to develop cancer genetic testing criteria through an evidence-based way where we review literature and we consider other testing guidelines that are out there and coming up with our guidelines. We use CLIA-approved U.S. labs for our testing, and we consider type of test, cost, and turnaround time. So to use an example of a patient who may come to Kaiser in Northern California or San Francisco specifically where I work, we have Louisa. She lives in Santa Rosa, which is about 55 miles north of San Francisco. And so San Francisco is circled there in the lower circle, and Santa Rosa would be just near the top of that circle. She's seen for a routine OBGYN appointment where she fills out a family history questionnaire asking about cancer in her family. Based on her family history of breast and ovarian cancer, her OBGYN discusses a referral to San Francisco Genetics Department. She's referred to us, and she's encouraged to complete our online genetics of breast and ovarian cancer class prior to her individual assessment because it gives important background information for her. So we have the option to first do a telephone intake appointment so we can obtain more details of her family history to start by phone, since it is a 1 to 1.5 hour drive to San Francisco. If she needs follow-up, she has option to drive to San Francisco for in-person follow-up, or we have an outreach genetic counselor who goes to the area near where she lives a few times a month, or we could consider a video visit. And imagine if Louisa lived in the far northeast of the state. The closest genetic center at Kaiser would be in Sacramento, which is where the arrow is pointing to, and so that's at least a 4-hour drive to her nearest Kaiser. So if we're talking about Louisa's genetics assessment, she's seen for in-person genetic counseling and to talk about an approach to genetic testing in her family. She does have a family history of breast and ovarian cancer on her paternal side, and she's of Guatemalan ancestry. Some of the issues that come up, there's different family members who may have different types of insurance or may not have insurance. And there's the person who is the best person to test, as we're all trained to know who that is in the family. But who gets tested might be different than ideal depending on who has insurance. The best person to test in her family is her cousin with breast cancer at age 39. But again, some things to consider. Does she have insurance? If she does, what are her copays or deductible? She's actually not covered under the Affordable Care Act because she's had cancer, so she would not be offered no-cost BRCA testing through that. There may be a lack of access to care or insurance or language barriers, or individuals may live in another country in the family where there may be no access to genetic services. Even her paternal aunt and her father are better candidates than herself, but if they live in the U.S., they have Medicare because they're over 65 and would not be qualified for testing, and it does not also cover an unaffected male, even if he were younger. They may be out of the country, or again, there may be cultural or linguistic issues. At Kaiser, Erica could be offered genetic testing for BRCA1 or 2 or in a multi-gene panel, but again, she's not the best candidate. So if negative, we would still want her cousin, father, or aunt to pursue genetic testing to really try and get her better information for an assessment.
So this is a map of Canada and illustrating our population density with the darker colors representing more dense populations. And you can see pretty clearly that the population is concentrated near the USA border. Ontario and Quebec, just to the right of center, are our most densely populated provinces. In general, across Canada, the provision of cancer genetic services is generally restricted to genetic counselors who are working in genetics clinics. Most provinces do provide services to the rural and remote regions by either video conference, by telehealth, or through outreach clinics. And the wait times for what would be considered a non-urgent appointment are going to vary across the country. Here in British Columbia, a non-urgent referral would wait probably about a year, and at least one province is reporting up to a 3-year wait. But there are much shorter wait times when somebody's referred for carrier testing, or if testing results may alter the medical management of the patient. And so, for example, in British Columbia, we can see patients in less than a week when test results are needed for those management decisions. In the sort of middle of the country, provinces like Manitoba and Saskatchewan, there may be only one genetics provider, and so that can make it very easy to find a service provider to either refer a family member to or to gain access to any genetic counseling records. In the more densely populated provinces like Ontario and Quebec, there may be multiple genetics providers across the province or even in the same city. And so to make a referral or find records for those individuals, you may need to know what city your patient lives in, or in Toronto, for example, you may actually need to know the specific hospital. Next slide. In terms of how we get through genetic testing in Canada, again, it generally starts with that gatekeeper role of physician who recognizes a significant family history of cancer in the patient and or the family, and they would refer the patient on to genetic counseling. Some clinics do allow self-referral. When the clinic receives that referral, they're probably first going to assess whether or not that patient meets eligibility for funded genetic counseling. If that family history is not significant enough and the patient is not deemed eligible, they may be able to access a private provider for genetic counseling services. And in this case, the patient would have to pay 100% of the cost out of their pocket. For patients who are eligible to receive funded genetic counseling, the next step is to determine whether or not the patient is eligible for funded genetic testing. If they're not eligible for funded genetic testing, some clinics, the genetic counselors will help to arrange privately paid genetic testing for the patient, and in that case, the patient would pay 100% of the test cost. If the patient is eligible for funded testing, then the test cost is 100% covered by their provincial plan. The specific criteria for who has access to genetic counseling and testing are going to be established by each provincial health plan, and so this access is going to differ significantly across the country. And just to give an example, some provinces will offer index BRCA1 and 2 testing to an unaffected individual if, say, their BRCA Pro score is high enough and there's no living individuals to test. But not all provinces have that option. Other provinces will offer some specific genetic testing for some unique regional mutations, such as in Newfoundland. Once genetics orders that genetic testing, whether it's publicly funded or private pay, genetics would report the results to the patient and then make management recommendations. And those management recommendations, again, are going to vary across the country depending on what the plan provides. To give you an example and highlight the approach in British Columbia, I'll use an example of Erica, who lives in the remote community of Kitimat. Erica is concerned about her risk for breast cancer and is considering bilateral mastectomy. She's referred by her GP to our Provincial Hereditary Cancer Program. After reviewing her family history, it is decided that she's eligible for a non-urgent genetic counseling appointment, and the current wait list is about a year. So this map is showing where Kitimat is in relation to our provincial clinic site in Vancouver. This is about a 17-hour drive or a flight, and the costs of travel are going to be completely the responsibility of the patient. You can appreciate that between the ocean and the mountains, there are going to be some significant seasonal issues of snow, fog, ice, making travel by car or plane difficult, particularly between October and March. Thankfully, British Columbia has an extensive video conference network that links all of the community hospitals throughout the province. And so Erica would be able to choose whether she wished to travel to Vancouver to be seen in person or to have a video conference appointment at her home in Kitimat. Looking at her family history meets our provincial criteria to offer genetic testing, but funded genetic testing has to start on an individual who has had breast or ovary cancer. So we would want to offer testing to her cousin who had breast cancer at age 42. If that cousin does live in British Columbia, she would be fast-tracked for an appointment because she's the best testable. And we feel that Erica's already done the wait list for the family, so we wouldn't put her on another wait list. If the cousin consented to genetic testing, we would offer her our 14-gene comprehensive panel with her results available in about 2 to 3 months. The panel includes BRCA1 and 2, P10, TP53, in addition to the Lynch and several polyposis genes. If that cousin, however, lives in another province or country, we would try to get her access to genetic services where she resides. If that's not possible, Erica's only option for testing would be to pay out of pocket, either for individual BRCA1 or 2 testing or a panel, and that would be at a lab of her choice. Our lab does not offer private pay genetic testing at this point, so we would be sending her sample outside of British Columbia for that analysis. Panel-based testing has really been very rapidly incorporated into cancer genetics. A November 2012 survey of the NFCC Cancer SIG showed 30% of genetic counselors had never ordered a multi-gene breast panel at that time. A survey done about a year later at the NFCC Annual Education Conference showed that this number was down to about 15%. A much larger group that was surveyed by one of the UBC graduate students in March of 2014 shows that there was little change in the rate in the U.S. genetic counselors, but you can see quite a significant difference between the Canadians and the Americans, with 77% of Canadian genetic counselors never having ordered a multiplex breast panel at that time. And that's pretty consistent with incorporation of new technologies into healthcare across Canada. The approach to using either a single gene versus panel-based testing is going to change as we go across the country. Most provinces are going to offer panels for Lynch testing, but this table is really highlighting some of the diversity of approach to a typical HBOC family. In British Columbia and Newfoundland, we don't start with BRCA1 and 2, but would immediately start with a panel. British Columbia has our in-house panel. Newfoundland would be sending their panel to a laboratory outside of the province. In Alberta, Manitoba, Nova Scotia, New Brunswick, and PEI, testing does start with BRCA1 and 2. And then, depending on the family tree, they may take an iterative approach to offering testing for additional genes. But at this time, panel-based tests are not covered by those provincial plans, but some provinces plan to offer them soon using their own provincial laboratories. And then finally, in Ontario, Quebec, and Saskatchewan, the approach really depends on the pedigree. So some of the clinics have created their own specific criteria for when to start with a panel versus when to reflex to a panel, and often decisions are going to be made on a case-by-case basis. For centers that don't have provincial labs that offer panel-based testing, they often will decide as a clinic what lab to use for all of their panels, and that's going to consider things like cost, the technology, the composition of the panel, and of course the turnaround time. I think we'll switch now to working through a few pedigrees and further illustrating some of the similarities and differences in our approach to who we would offer genetic testing to, what type of testing we would offer, and what are some of those turnaround times. So our first patient here is an unaffected 48-year-old woman with a maternal family history of young onset breast and colon cancers with possibly some brain and uterine primaries. In British Columbia, we have no publicly funded genetic testing to offer this patient. We could try to get her distant relative who's had breast cancer in, but this really would not address her whole family history. We would also try to get the tumor tissue from her uncle's colorectal cancer for IHC analysis. Now, if that individual lived in BC, that would be funded. The turnaround time would probably be about 4 weeks to get those immunohistochemistry results. If those results were supportive of Lynch syndrome, we may be able to offer our 14-gene panel to his first-degree relatives, and those results would take another 2 to 3 months to be reported. Now, in some other parts of Canada, this unaffected patient would have funded BRCA1 and 2 testing, and the turnaround time ranges anywhere from 2 weeks to 9 months, depending on the provincial laboratory. If her results were uninformative, it'd be quite unlikely that a panel-based test would be funded, so she could, of course, choose to do that out of pocket. And then just to highlight some of the difficulties, we have had a situation where one of the unaffected relatives had a panel-based test done in the United States, and a PALB2 mutation was identified. And in some provinces, we may not be able to offer funded PALB2 testing to our patient because it's not yet recognized as a clear cancer susceptibility gene with published management guidelines, and therefore testing for that gene may not be covered by the provincial plan, and the patient would have to pay out of pocket. Access to her screening and management may also be complicated because of those lack of published guidelines. Christine, do you want to give it a go?
Yeah. So at Kaiser, given there is one affected individual, but they're pretty far removed over here. So we, of course, would want to try and get that individual tested somehow. But that, again, would not address the rest of the family history since there is cancer on the other side of the family. So we would offer genetic testing to the unaffected 48-year-old. And similarly, we would also recommend considering MMR IHC on the colon cancer up here, but it would not be paid for by the patient's Kaiser insurance. It would be an out-of-pocket expense to the family. We would still help to try and coordinate it if possible, though. And so at Kaiser, we would offer her the option for a multi-gene panel, currently doing 24 genes, but she would have the option to do BRCA only or a smaller panel if she wanted. The turnaround time would be about 2 to 4 weeks, depending on whether it's just BRCA or whether it's a panel. Outside of Kaiser, this patient would meet NCCN guidelines for cancer risk assessment and consideration of testing. Most insurance companies, including the Affordable Care Act, would authorize genetic testing for her, including BRCA1 and 2. But whether inside or outside of Kaiser, if doing at Kaiser, genetic testing would depend on the plan that she has as to how much she has to pay. And doing a panel, if she was able to get a panel authorized outside of Kaiser, that would also depend on her plan and how much she would have to pay. Again, some of the labs are doing panels for free or included if BRCA testing is authorized by the insurance. In terms of the PALB2 piece of it, here at Kaiser, we would test her for a PALB2 mutation, discussing the limitations of the current information about that gene and taking her family history into account for thinking about screening if she did test positive or if she were negative. And whether or not that would be covered outside of Kaiser would depend on her type of insurance And again, sometimes there needs to be a letter of medical necessity from a genetic counselor or another healthcare provider to help get genetic testing if it's not one of the standard genes that would be included in a genetic testing policy for an insurance company.
So in this next category, the patient had a pancreatic neuroendocrine tumor, and that was later followed by an invasive ductal breast cancer, and these were both diagnosed at pretty young ages. Her paternal history includes prostate and ovarian cancer, and you can see her maternal history includes breast, colon, renal, skin, and possibly some stomach cancers. So the patient is clearly the best testable family member, and she meets criteria for testing through both sides of her family. To me, this is exactly the kind of history where you would want to start with a panel, as you know, the differential includes BRCA, Lynch, possibly Cowden's. And I think it's also important to note that maybe there's more than one mutation in this family. There was a recent abstract at the San Antonio Breast Cancer Symposium where in a cohort of about 400 patients who did have deleterious mutations, 2.7% of those patients had more than one deleterious or likely deleterious mutation. So if we limit testing to just looking at a single gene and we find a mutation, we may be erroneously interpreting risk throughout the family. Of course, our ability to detect a second mutation is really going to depend on what genes are on that panel. And, you know, sometimes we're restricted by the panels that are provided by our provincial laboratories. So if this patient was referred to us when genetic testing might actually impact her treatment-related decisions, let's say she's considering bilateral mastectomy with her breast cancer diagnosis, in BC, we would probably pay to send her test out to a U.S. lab for that targeted BRCA1 and 2 testing so we could get a fast turnaround time. If her results were uninformative, I would have no further testing to offer her because she doesn't personally meet the criteria for any other genes on our panel. If, however, she presented for testing and the results were not considered urgent, then we would start with our 14-gene panel with those results reported in about 2 to 3 months. We would also try to arrange MSI and or IHC on her brother's colorectal cancer. And if neither of those proved to find anything definitive, we would offer our patient the option of participating in a research protocol that may be locally, maybe nationally, or maybe an international protocol.
Okay, great. So if the patient were at Kaiser, again, based on her personal and family history of cancer, we would be at baseline offering a multi-gene panel to her. The extent of that panel depends a little bit on other assessments. And again, if she were just recently diagnosed with her breast cancer, we would be talking about, of course, getting the testing back as soon as possible, but it probably wouldn't change all that much whether she was just diagnosed or diagnosed a few years before and coming to us later, because all of the turnaround times are within about 2 to 4 weeks for the test that we would be doing. We would also want to try and do IHC on her brother's colon cancer if possible, because that might inform, especially in the context of our panel results, depending on what comes back. And in terms of addressing her pancreatic neuroendocrine tumor, we would offer a geneticist appointment to complete a thorough medical history, physical exam to look for some of the cutaneous manifestations of more rare syndromes, so for MEN1, facial angiomas, collagenomas, lipomas, and we would also offer a serum biochemical workup for MEN1. If the geneticist evaluation and biochemical evaluation were normal, it's unclear whether we would still consider a more extended panel, and we do have a local meeting that we bring complicated cases to on a weekly basis. And the discussion would be, do we cast a wide net because we can and include any genes that have association with neuroendocrine tumors, or do we stick to clinically relevant genes or suspected relevant for her situation? And if she doesn't have any other features of MEN1, for example, would we include MEN1 on a panel? We would also encourage DNA banking for the patient as an option for her family members to consider should she pass away at some point in the future and there's additional genetic testing. If the patient were outside of Kaiser, it would, again, depend on their medical plan. Since she's affected, she does not fall into the category for no-cost BRCA testing under the Affordable Care Act. But interestingly, her unaffected sister would qualify for Affordable Care Act no-cost testing. Insurance might not cover a panel, but the lab might do it anyway. And again, there might need to be a letter of medical necessity to consider anything beyond that standard BRCA 1 or 2 test. So moving on to cancer risk management for our family history assessment part. Just generally speaking for the NCCN, most people know that these are developed based on literature review and expert opinion. They're updated at least yearly. And there's two main categories that fall into the genetics assessment, one for breast and ovarian cancer and the other for colorectal cancer. And both of these have several genetic syndromes under them for the guidelines. Insurance companies and medical providers look to these guidelines to make their own guidelines, or they may use the NCCN guidelines directly for their patients.
And that's fairly similar to what happens across Canada. Provincial guidelines for management are loosely based on NCCN guidelines, but are going to be based on that combination of literature review and expert opinion. And again, what's available across the country is going to vary province to province. Some of that may be related to MRI, for example, how many machines are there, how many providers are there, and so the accessibility of MRI may be limited because of some of those factors and may not be in keeping with NCCN recommendations. If we go back to our initial patient, Erica, what sort of management options would we offer to her? So again, in British Columbia, if either no genetic testing is performed on her because she's unaffected, or let's say we get uninformative results on her cousin, we would offer her annual mammograms, or she'd have the option of prophylactic mastectomy with reconstruction. She could also choose prophylactic bilateral salpingo oophorectomy, and those costs are all going to be completely covered by our medical services plan. Some patients, like Erica, may be frustrated because we're able to cover the cost of surgery, but we wouldn't cover the cost of her genetic testing. In the absence of any genetic testing, some provinces in Canada will offer Erica breast MRI as long as her calculated lifetime risk for breast cancer is at that 20% or higher. In British Columbia, we can only offer a breast MRI to women who either have confirmed mutations or who are at 50% risk for a known mutation in a high-risk breast cancer susceptibility gene. We do not recommend ovarian cancer screening in British Columbia, but there are some provinces where the options still include that CA125 and pelvic ultrasound. In terms of some of the wait times for, let's say, the prophylactic mastectomy or the BSO, it can be a year or two, with shorter waits expected for women who are known to have mutation, particularly for the gynecological surgery. But remember that our patient Erica lives off in a remote community of Kitimat, and for her, how does she access a mammogram? So often we have a mobile digital mammography van that would visit her community on an annual basis, so she could get her mammograms that way. But if she was going to access breast MRI or surgery, she would have to travel to Vancouver. And so those travel costs and the implications may have a significant impact on her choices to pursue either of those options. Christine?
Okay. Yeah. And if Erica were living in San Francisco and had Kaiser insurance, if she had no genetic testing, or if she were an uninformative negative, or if she does have a mutation, then she would be offered high-risk breast and ovarian cancer screening based on her family history, which would include yearly mammogram and yearly breast MRI, and every 6 months transvaginal ultrasound and CA125. Of course, we would discuss the benefits and limitations of all of the screening, particularly with the ovarian cancer screening, the limitations of that. And in terms of her risk-reducing options, she would be a candidate to consider risk-reducing mastectomies and risk-reducing bilateral salpingo oophorectomies. And again, these would be considered medically indicated based on her family history, but the cost she has associated with that might be very different depending on the type of insurance plan she has. In terms of access to services, again, depending on where she lives, would depend on what specialists are near her and whether she has to travel to see anyone else. In San Francisco, we have a women's hereditary cancer risk clinic where we actually have several specialists under one roof. at one appointment where the patient can see a gynecologic oncologist, breast surgeon, plastic surgeon, nurse practitioner, and genetics all in one visit. Those are for San Francisco patients. And so that's what we would be able to do for her if she were at Kaiser in San Francisco. So to touch on some resources for you, in terms of genetic discrimination protections, in the U.S., there's the Genetic Information Non-Discrimination Act, or GINA, signed in 2008 into federal law. It's protection against health insurance discrimination and employment discrimination. There are no protections for other types of insurance, such as life insurance or long-term disability. States may also have their own laws, which in fact may have been in place even before GINA was signed as an act. And so there are also protections at the state level.
In Canada, we do not have any legal protection from genetic discrimination, but because we have universal coverage through the Canada Health Act, nobody's ever going to be discriminated against for health care access. So really, it's issues about insurance discrimination. Even travel health insurance can be a significant issue for some patients who, we call them the snowbirds. They travel to the U.S. To weather the winter in warmer climates. We did recently have a anti-discrimination bill in our House of Parliament. Many genetic counselors participated in defending that bill, but it failed to pass. And so there'll be a lot more work before we've got any legal protections in place. The other thing important to note that the Canada Health Act does guarantee accessible and portable coverage. So as Canadians travel across the country or outside of the country, they do still have some coverage, but each province will only pay what those services would cost in their home province. So that may not vary dramatically across Canada, but can certainly be really different if you're accessing a medical service in the U.S. In terms of some cross-border tips for you, it may be worth thinking about waiting to have the best testable patient referred for genetic testing in Canada. The wait for that appointment may actually be shorter than you think and may have significant impact on genetic test options, screening and management options for your patient in the U.S. In addition, patients that don't qualify for funded testing in one of our Canadian provinces, they may have a family member in another part of Canada or in the U.S. that does qualify, depending on their insurance or their health care plans and what's covered. Also, is it possible that testing might be done on a relative elsewhere while your patient is sitting on a wait list? So if you've got a 2 or a 3 year wait list for non-urgent appointments, are there other people that it makes more sense for them to be seen, and they may have shorter wait lists? And that's certainly been useful for some of my patients who were seen faster in the U.S. And by the time my patient had their appointment, we had results on their family member, et cetera, and we could be much more efficient. And then last of all, just to remember that each Canadian province has a unique health insurance plan, so what's covered in one area may not be covered in another.
And another thing that's important to realize is that not everyone in the U.S. can, quote, just get testing. So I talked a lot about how there may be insurance issues or co-pays. People may be insured or underinsured or uninsured, and what actually gets paid for. A wait list for genetic counseling may be longer than you think in the U.S., depending on where the patient is going to get their care. And some people will go to their primary care doctor or other healthcare professional for testing, but will they get the right test? And if they only get one shot at genetic testing with their insurance and there's a recommendation to do something else, will they be able to get it covered? There's cultural aspects of genetic counseling that are unique both between and within the U.S. and Canada. So there may be things that are unique between the U.S. and Canada, but also within our countries. Both countries have very diverse populations and unique cultural needs, and people living just across the border may actually share more similarities across that border than to other people within their same country who live geographically much further away within the same country. And the last thing to consider is that our ideal approach is generally going to be the same between the U.S. and Canada. We all went to programs that taught us how to do cancer genetic counseling, and that, one basic thing would be test the affected family member first, the youngest affected family member. So those basic tenets, those basic approaches are going to be the same. How those end up playing out can be very different depending on the availability or restrictions of the systems that we're working under. So just as a resource, as I'm sure everyone knows, you can go to the National Society of Genetic Counselors, nsgc.org. In the bottom right corner there, find a genetic counselor where you can search by location, city, zip code, distance to services, even by specialist.
And while many Canadians are going to be listed on the NFCC site, also remember that there's the Canadian Association of Genetic Counselors that has a very similar search option. So you can search by province, you can search by specialty, and you can find a genetic service provider quite easily through their links. Thank you.
Hi, and thank you, Christine and Jenna. Well, I think we are over a minute or two here, so just separately, I also want to mention that we at Ambry have another educational webinar opportunity next week on June 9th, 1 week from today, but the topic will be on cardiovascular genetics. It's entitled Straight from the Heart, Evaluation in Genetic Testing for Sudden Death, and you can check out our website for more details, including registration. So thank you, everyone, again for joining us, and have a wonderful rest of your days.